intercostal space. Okay, so that takes care of the surface anatomy of the lung. Now, what we want to do is turn our attention to the surface anatomy of the heart. And on this illustration, what we can see is a structure or a region inside the chest that's sort of seen as a shadow behind the chest wall. And this would be similar to the shadow that you would see in a chest x-ray. And the shadow is often referred to as the heart shadow. But as we'll very shortly see, it isn't really the heart shadow, because it includes not just the heart, it includes the heart and all of the other mediastinal structures, all of the other structures between the two pleural cavities, between the two lungs. So what we'd like to do is take a look at this surface projection of the mediastinal shadow and see which part of it is actually the heart, and then pay attention to the details of the surface anatomy of the heart. So what we're going to do is superimpose on this image the outline of the heart. So we'll take this picture of the heart as it exists in the chest and superimpose it on the chest wall and create the outline of the heart. So the way we will do that is to identify the points that would represent the four corners of the heart, and then we can connect those 4 points with lines and thereby create the outline of the heart. So the upper right corner of the heart is found behind the 3rd costal cartilage on the right side, about 1/2 an inch from the sternum. The lower right corner of the heart is at about the level of the 6th costal cartilage, also about 1/2 an inch to the right of the sternum. The upper left corner of the heart is behind the 2nd costal cartilage, about a half an inch to the left of the sternum. And then the lower left corner is in the 5th intercostal space at a point that would be approximately at the midclavicular line, which is about 3.5 inches from the sternum. So the 5th intercostal space at the midclavicular line would be the lower left corner, which is also called the apex. And if we connect those 4 points with just slightly convex lines, we now have the outline of the heart. And just with that much information, just with that outline of the heart, we would now be able to anticipate whether an object penetrating an intercostal space, a knife wound for example, whether a knife wound, depending upon which part of the chest wall it penetrated, whether or not it would injure the heart. But we would like to have much more information than that, so we can be much more specific with regard to parts of the heart. So let's add to this outline some of the landmarks that can be seen on the wall of the heart itself. And let's start by putting in the coronary sulcus. That's where the coronary sulcus would be found on the anterior chest wall, on the anterior surface of the heart, and that's where it would project onto the anterior chest wall. In other words, just about parallel with the right border of the sternum. Now, it's very helpful if we remember that the other name for the coronary sinus is the atrioventricular sinus. Those are synonymous terms, atrioventricular sinus or coronary sinus. And that name, atrioventricular sinus, tells you that sulcus is separating atrium from ventricle. So since this is the right side of the patient, we can anticipate that on one side of the line will be right atrium, and on the other side of the line will be right ventricle. And that's true. Now let's add the other major landmark on the front of the heart, and that is the anterior interventricular sulcus, which would be approximately there, the anterior interventricular sulcus. And that name, interventricular, tells you precisely what that sulcus is. It is a sulcus or a groove between the ventricles. So it's separating one ventricle from the other. And since we've already said that this is right ventricle, that means if we go to the other side of that line, that must be left ventricle. And that's true. Now, if we come back for a moment to the coronary sulcus, let's remember why the coronary sulcus is called coronary. Coronary is from the root meaning crown, corona, like coronation. So it's called the coronary sulcus because it circles the heart in the way that a crown would circle the head. So the point here is that when we follow this coronary sulcus down the front of the heart, when we reach the bottom, it doesn't end at that point. It circles the heart. It goes around the back of the heart. It would go across the back of the heart until we get to the left border of the heart, and then it would come back around the front of the heart. And so we would see the continuation of the coronary sulcus right there. And since we've already said that the coronary sulcus is the same thing as the atrioventricular sulcus, that means that that line is separating atrium from ventricle. We've already said that this is the left ventricle, so on the other side of that line, that should be left atrium, and sure enough, that's what it is. So now, by simply adding the surface projections of the coronary sulcus and the interventricular sulcus, we now can take this outline of the heart and subdivide it and know where the chambers are. So now if we had a penetrating wound and said, for example, the penetrating wound was in the right fourth intercostal space at the sternal border, now we would be able to say more than just that it might injure the heart. We would say it might injure the right atrium. If it was in the left fourth intercostal space at the sternal border, now we could say it could injure the right ventricle. If it was in the left fourth intercostal space a couple of inches away from the sternum, then we might say it would injure the left ventricle, and so forth. This also allows us to look at the overall outline of the heart and be able to say that the entire right border of the heart is being formed by the right atrium. We see that most of the left border of the heart is being formed by the left ventricle, with just a little bit of the upper side, the upper end of the left border being formed by the left atrium. We see that most of the anterior wall of the heart is being formed by the right ventricle. So if we take that outline, that surface anatomy, and relate it to what we actually see on the heart, sure enough, we see that the right border of the heart is being formed by the right atrium. Here's that coronary sulcus that we talked about. Here's where the interventricular sulcus is. There's a blood vessel sitting in it that's marking its position. We'll talk about that later on. So between there and there, all of this is right ventricle, forming the anterior wall of the heart, most of the anterior wall. We said most of the left border is going to be left ventricle. That's what we see here. There's the coronary sulcus again. And so there we see a little bit of the left atrium, the little, what's called the auricular appendage of the left atrium. So we see the upper portion of the left border is left atrium. While we're looking at this, we can also take note of the following. We see that coming into the right atrium from above is going to be the superior vena cava. So we would anticipate that the right border of the shadow that we see in an X-ray, which over here would be right atrium, as we follow it up, that would be superior vena cava. We see that coming out of the front of the heart, we have two major outflow vessels. One is the ascending aorta, and the other is the pulmonary trunk. And take note of the fact that the ascending aorta is to the right, the pulmonary trunk is to the left. Now that may initially seem like it's backwards to you, since we know the ascending aorta comes from the left ventricle, the pulmonary trunk comes from the right ventricle. It looks like they must have crossed one another in order for the ascending aorta to be to the right, and in fact they do. And why they are arranged that way is something we'll understand when we take a look at the embryology of the heart. So there's the ascending aorta, there's the pulmonary trunk. The pulmonary trunk is dividing into its two pulmonary arteries, left and right. And over here we see that the ascending aorta arches around to become the aortic arch. So when we look at the left border of the shadow, the heart shadow, we'd expect to see is that the left ventricle makes up most of the left border, a little bit of left atrium. Then we'd expect to see the left pulmonary artery, and then we'd expect to see the aortic arch. So let's now turn our attention to an X-ray, a frontal or an AP projection, or this could easily be an AP or a PA projection, but a frontal projection of the chest. And we can see that what's called the heart shadow, which we now know is more than the heart, it's the mediastinal shadow. And as you can see from the labels, the right border of the heart shadow is being formed by the right atrium, The upper portion of that right border is being formed by the superior vena cava. The left border of the heart shadow is primarily left ventricle, the upper part left atrium. Above that we see the left pulmonary artery, and above that we see the convexity of the aortic arch. If we turn the patient laterally and did a lateral chest film so that we can see the anterior and posterior borders, what we can see is that the anterior wall, we already know that most of the anterior wall is right ventricle, and so that would be the right ventricle. Now, when we looked at the heart, we saw very little of the left atrium from this anterior view. Only this tiny little bit of left atrium comes around to the front, and that should suggest to us that most of the left atrium is on the back wall of the heart, and indeed it is. In fact, the entire posterior wall of the heart is left atrium. And so looking at this posterior surface of the heart shadow, that's the left atrium. And then lastly, we can say that this inferior wall, or diaphragmatic wall, the surface of the heart that's resting on the diaphragm, is composed primarily of the left ventricle. So those 5 borders and surfaces are critically important in understanding the surface anatomy of the heart. So to review it, what we're saying is that the right border is right atrium primarily, entirely. The left border is primarily left ventricle. The anterior wall is primarily right ventricle. The posterior wall is entirely left atrium, and the inferior or diaphragmatic wall is left ventricle. Those are very important landmarks if we want to be able to interpret chest films or CT scans or physical exams or anything else relating to diagnostic procedures in the chest. Now, let's use our knowledge of the surface anatomy of the heart to understand auscultation points in the heart. And what we're going to be talking about here are the auscultation points for the normal heart sounds made by the closure of the 4 valves of the heart. And what we should understand is that there's a general principle that applies to where these auscultation points are going to be found. And if we understand the general principle, we don't have to memorize the auscultation points because we can infer them or derive them. And the principle is simply this, that the sound generated by a valve, in this case the closure of a valve, the sound generated by a valve will be heard best downstream from the valve, not directly over the valve, not by placing the stethoscope directly over the valve, but rather by placing the stethoscope over the region downstream from the valve. In other words, where the blood flows after passing through that valve. Where does the blood go? So let's apply that one valve at a time. The tricuspid valve is the valve found between the right atrium and the right ventricle. And so blood normally is flowing through that from right atrium to right ventricle. So downstream means right ventricle. So if we want to hear the closure of the tricuspid valve, we want to be over the right ventricle. We've already said that the right ventricle makes up most of the anterior wall of the heart, and we know a whole lot of the right ventricle is behind the sternum, so that wouldn't be a good place to hear it. So we want to hear it over an intercostal space where you don't have bone in the way. And we know that as we go to the bottom of the heart, which would be a good place to go because, as we can see here, the bottom of the heart is closest to the anterior chest wall. If we go to the bottom of the heart, which would bring us into the 5th intercostal space, we know the further away from the sternum we get, the more our chances are of being over the left ventricle instead of the right ventricle. And therefore, if we stay in the 5th intercostal space right alongside the border of the sternum, we can be very confident that our stethoscope will be over the right ventricle, and therefore that should be the auscultation point for the tricuspid valve because the right ventricle is downstream from the tricuspid valve. So that's where it is. The mitral valve is the valve between the left atrium and the left ventricle. So the blood is going downstream to the left ventricle. So if you want to hear the mitral valve, you want to be over the left ventricle. So that in this case, we would go all the way to the left border, to the apex. Again, be at the bottom because that's closest to the chest wall. So that's the apex. We've already said that that's the 5th intercostal space in the midclavicular line. So that should be the auscultation point for the mitral valve. The aortic valve is between the left ventricle and the ascending aorta. So blood is going from the left ventricle to the ascending aorta. So the ascending aorta is the downstream region. And remember, we said the ascending aorta goes up and to the right from the heart. So we want to go up and to the right. And actually that little spot should be in the intercostal space, not on the rib. So right about there is where you would best hear the aortic valve closure, in the second intercostal space just to the right of the sternum. And similarly, since the pulmonary valve or pulmonic valve is between the right ventricle and the pulmonary trunk, so the blood is flowing to the pulmonary trunk, and since the pulmonary trunk goes up and to the left, placing our stethoscope in the left second intercostal space is where we would hear the pulmonic valve closure. So all four of these auscultation points are based upon exactly the same principle and can be derived the same way. And although it would not be appropriate to spend our time doing this right now, we can use the same principles to understand why we hear valvular murmurs, whether they be systolic murmurs or diastolic murmurs or stenotic murmurs or regurgitation murmurs. Regardless of which kind of murmur it is, if we understand that general principle of listening for the sound downstream from the valve by following the direction of blood flow, that will enable us to figure out where the best place would be to hear each of those murmurs. Let's now turn our attention to other features of the adult heart. And let's just take a moment to take a look at the pericardium. Just like the lungs were surrounded by pleural cavities, the heart is surrounded by a pericardial cavity, and much of the anatomy is really the same. Remember, in the pleural cavity, we had two layers of pleura with a cavity in between. The inner layer was called visceral, the outer layer was called parietal. We have the same thing in the heart. The inner layer is called visceral pericardium. It's fused to the surface of the heart. The outer layer is called parietal pericardium. And between those two layers is a cavity, which is called the pericardial cavity. So that's the same thing. What is different is that surrounding the heart there is a third layer. There's not just the visceral and the parietal layer, but there's an outer third layer called the fibrous pericardium. And the fibrous pericardium is fused with the parietal pericardium. And the important point about the fibrous pericardium is that it is fibrous and it doesn't stretch. So that means that if you get a rapid accumulation of fluid in the pericardial cavity, such as bleeding into the pericardial cavity, because you have this rapid filling of the pericardial cavity, and because the fibrous pericardium doesn't stretch, it doesn't allow the pericardial cavity to expand outward, which means that the pericardial cavity will expand inward. And because it's expanding inward, that means it's going to be compressing the heart. And that compression of the heart is going to interfere with cardiac filling during diastole, so that will result in a reduced end diastolic volume, which will result in a reduced stroke volume, which will result in a reduced cardiac output, reduced blood pressure, and so forth. So that becomes a life-threatening situation. So that situation, which is called cardiac tamponade, the increase of pressure in the pericardial cavity because of fluid in the pericardial cavity, occurs as a result of the fact that there is a fibrous pericardium that does not allow the pericardial cavity to expand outward. So under those circumstances, the fluid would have to be removed by pericardiocentesis in order to relieve the pressure on the heart. And that's an emergent situation. Okay, let's now take a look at the blood supply to the heart. The heart is supplied typically by two coronary arteries, a right and a left coronary artery. They are both direct branches of the ascending aorta. They are the only branches of the ascending aorta. And what we see on this figure is that the right coronary artery leaves the ascending aorta from the right side, and it immediately enters the coronary sulcus. That's the right coronary artery. Remember, the coronary sulcus is also the atrioventricular sulcus because it sits right between atrium and ventricle. And so since the right coronary artery is sitting right between the right atrium and the right ventricle, no surprise that what it supplies is the right atrium and right ventricle. In fact, what we'll see is that all of these coronary arteries and their branches simply supply their immediate surrounding neighborhood. As long as you know where the vessel is, you know what it supplies. So this right coronary artery is in the coronary sulcus between right atrium and right ventricle. And we know that the coronary sulcus continues around the back of the heart, and so the right coronary artery continues around the back of the heart, staying in that coronary sulcus. As it reaches the border of the heart, it gives off a branch called the marginal artery that simply sits on the surface of the right ventricle, so it's going to be supplying right ventricle. But the right coronary itself continues in the coronary sulcus around the back of the heart. While on the back of the heart, it gives off a branch that enters the interventricular sulcus on the posterior wall of the heart, and that's called the posterior interventricular artery. Sometimes it's also called the right posterior descending artery. Since it's interventricular, that means it's sitting between the two ventricles. What it will supply is the two ventricles, right and left ventricle, posterior wall of right and left ventricle, and the posterior part of the septum. Okay? So that's what the right coronary does. The left coronary artery is really quite different. It's a very short artery. The right coronary is pretty long. It goes all the way around to the back of the heart. The left coronary is pretty short. It's only about an inch long. It's just long enough to get past the pulmonary trunk. And as soon as it gets past the pulmonary trunk, it ends by dividing into two branches. One branch is the circumflex branch of the left coronary artery. And that circumflex artery, the circumflex branch, enters the coronary sulcus. And it stays in the coronary sulcus going around to the back of the heart. And again, coronary sulcus is atrioventricular sulcus. In this case, it's between the left atrium and left ventricle. So the circumflex artery is supplying the left atrium and left ventricle. Now, since the circumflex artery is in the coronary sulcus and the right coronary artery is in the coronary sulcus, those two arteries are coming toward one another, and that provides the opportunity for communications between those two vessels. And in fact, there are communications between those two vessels, that is anastomoses, that allow for anastomoses between a branch of the left coronary and the right coronary, so that if, for example, there was a partial occlusion of the right coronary artery and a decreased blood flow in the right coronary, by way of the circumflex branch, the left coronary can be supplying areas that normally would be supplied by the right coronary. The other branch of the left coronary is the anterior interventricular artery, also commonly called the left anterior descending artery. And since it's interventricular, it sits in the interventricular sulcus. That means it's between the right and left ventricles, so it supplies right and left ventricles. And the anterior interventricular, or LAD, is in the interventricular sulcus, which is the same place that the posterior interventricular is, and so they're coming toward each other end to end. So again, we have the opportunity for anastomosis between a branch of the right coronary and a branch of the left coronary. So the same situation obtains. Partial occlusion of one artery can be overcome by the communications so that the other artery can take over. Okay? That's the arterial supply. If there's an arterial supply, there must be a venous drainage, and there is. And the veins of the heart are called cardiac veins, not coronary veins, cardiac veins. And there's not a lot that we need to say about the cardiac veins, other than to say that most of the cardiac veins, not all, but most of the cardiac veins drain into one large vein. And that big vein is called the coronary sinus. We can see that sitting here on the posterior side of the heart, right between the left atrium and left ventricle in the coronary sulcus. So there's the coronary sinus, and we can see that draining into the coronary sinus is lots of other veins, cardiac veins. And then the coronary sinus drains into the right atrium, as you can see right here. So remember that coming into the right atrium are not only the two vena cavae, but a third large vein also comes into the right atrium, and that's the coronary sinus, containing the venous return from the heart itself. Okay, now let's turn our attention to the cardiac conduction system. Now, in order to understand the cardiac conduction system, there's a couple of fundamental issues about cardiac muscle that it's important that we understand. And particularly, we want to understand what makes cardiac muscle different from skeletal muscle. And there are two important features that I want to address. The first is the following. Skeletal muscle cells have polarized membranes that remain polarized unless you do something to depolarize them. When you depolarize them, the muscle will contract. So the contraction of the muscle is linked to the depolarization of the membrane. That's called the excitation-contraction coupling mechanism. So when the membranes are depolarized, the muscles will contract. But those membranes will not depolarize unless you do something to them to make them depolarize. And normally what's done to them is that the nerve innervating that muscle depolarizes, releasing acetylcholine, which then will result in eventually depolarization of the muscle membrane. But if that nerve going to that muscle is damaged so that you don't innervate the muscle anymore, the muscle doesn't depolarize, therefore it doesn't contract. That's why it's paralyzed. In contrast, cardiac muscle has a membrane that's also polarized, but it spontaneously depolarizes. If you just leave it alone, it will depolarize, and then it will repolarize, then it will depolarize, and it will repolarize. Because the membrane is different at a molecular level. We won't talk about that in this discussion. But the point is that cardiac muscle spontaneously contracts because it spontaneously depolarizes. So that's a major difference. The second major difference is that skeletal muscle cells do not electrically communicate with their neighboring skeletal muscle cells. One skeletal muscle cell does not know what its next door neighbor muscle cell is doing. So if one skeletal muscle cell depolarizes, it has no effect on the next skeletal muscle cell. In contrast, cardiac muscle cells are electrically communicating with their neighboring cardiac muscle cells. There are specializations of the membrane called gap junctions, which are found at the intercalated discs of cardiac muscle, so that when one cardiac muscle depolarizes, the next cardiac muscle cell depolarizes. So, putting those thoughts together, what we now can say is that each cardiac muscle cell is spontaneously able to depolarize. The rate at which it depolarizes will be different for different cells. However, when any cardiac muscle cell depolarizes, they'll all depolarize because they are electrically communicating. Therefore, that means that whichever cardiac muscle cell depolarizes the fastest will force all other cardiac muscle cells to depolarize at that rate. That brings us to the cardiac conduction system. If we look at the heart, what we will find is that in the wall of the right atrium, right next to where the superior vena cava enters the right atrium, there is a group of specialized cardiac muscle cells. Those cells collectively called the sinoatrial node. And what makes these cells special is that they depolarize faster than other cardiac muscle cells. Whereas all of the other cardiac muscle cells in the heart may depolarize somewhere in the 35 per minute to 45 per minute range, the SA nodal cells will spontaneously depolarize at the 65 or 70 per minute range, approximately. So since they are depolarizing the fastest, they will force the other cells to depolarize at their rate, and therefore we would call that the pacemaker. That's setting the pace. So the sinoatrial node serves as the pacemaker for the heart, and the reason that can do that is because these cardiac muscle cells are electrically communicating with one another. So the depolarizations of the SA node get spread to the other cardiac muscle cells. However, there's an important feature that we have to address at this point. Even though we said cardiac muscle cells communicate with one another, that's not entirely true, because there is in the heart a layer of fibrous connective tissue that separates the atria from the ventricles. It's called the fibrous skeleton. Fibrous connective tissue does not conduct membrane depolarizations. In essence, it serves as a layer of insulation. So we have this layer of insulation separating the atria from the ventricles. So even though the atria are electrically communicating, the cells of the atria are electrically communicating with one another, and the cells of the ventricle are electrically communicating with one another, because of this fibrous layer, the fibrous skeleton, atrial cells are not communicating with ventricular cells. So that would mean that the sinoatrial node, the SA node, is able to drive the atrial cells, but it wouldn't be able to drive the ventricular cells. So that's not very good. We need the ventricles to know what the atria are doing. And so the way we address that is there is a single defect. There's a defect in that layer of insulation. Basically a hole in the layer of insulation. Right there. And passing through that defect, there is a bundle of specialized cardiac muscle passing from the atrial septum to the ventricular septum, and that bundle is called the atrioventricular bundle, or the common bundle, or the bundle of His. All means the same thing. And that common bundle, or AV bundle, or bundle of His, passes from the atrium to the ventricle, and therefore is able to carry the atrial depolarization to the ventricle. And once it's in the ventricle, since all of the ventricular cells are communicating with one another, we now are able to have the sinoatrial node not only drive the atrium, but also drive the ventricle. But there's one more issue we have to address. If nothing else were to occur, the problem we would have with this model is that while the ventricles are depolarizing at the same rate as the atria, they also would be depolarizing at the same time as the atria, so that ventricular contraction, or ventricular systole, would coincide with atrial contraction. And that's not what we want. We want ventricular contraction to come slightly after atrial contraction in order to give the ventricles time to finish filling during atrial systole. So we want the ventricles to depolarize at the same rate as the atria, but not at the same time. We want there to be basically a phase shift. So how do we accomplish that? Well, there's another specialized bundle of cardiac muscle cells right here, and those are called that's collectively called the atrioventricular node, the AV node. And there are two important points about the AV node. The first is that the only electrical pathway into the AV bundle is through the AV node. The only way an impulse gets into the AV bundle is through the AV node. And the second point is that the AV node, what makes those cells special, is that they slow down the velocity of the propagation of the depolarization. That is to say, the depolarization passes through the AV node more slowly than it passes through any other cardiac muscle. And so that means that when the depolarization reaches the AV bundle, it's a little bit later than when it has reached all of the atrial cells, because it was slowed down in getting to the AV bundle by the AV node. And since it gets to the AV bundle a little bit later, therefore it gets to the ventricle a little bit later, therefore the ventricle depolarizes a little bit after the atria depolarize. So they're depolarizing at the same rate as the atria, but not at the same time. And if we correlate what we just said structurally to what we see in an electrocardiogram, and on this electrocardiogram we see the typical P wave, QRS complex, and T wave, all that we need to address here is that the P wave represents atrial depolarization, the QRS complex represents ventricular depolarization, and so this gap in time between the P wave and the QRS complex, which is called the PR interval, in other words, that length of time from there to there, is the time lag that was imposed by the AV node. So what we can say is that the sinoatrial node controls how many times per minute this sequence of depolarization occurs, and the AV node controls the length of the PR interval, how long the gap in time is between atrial and ventricular depolarization. The more the AV node retards depolarization, the longer the PR interval will be. The less it retards depolarization, the shorter the PR interval will be. The last point to be made is that throughout this discussion of the cardiac conduction system, I really didn't use the word nerve. And the point here is that none of this cardiac conduction system is composed of nerve fibers. It's all specialized cardiac muscle. The SA node, the AV bundle, all of that is specialized cardiac muscle. which means all of this functions without any nerve being necessary. That doesn't mean that the heart doesn't have a neural innervation. It has a very rich neural innervation, sympathetic, parasympathetic, and sensory. And the point here, and we'll just address the sympathetic and parasympathetic, the point is that while the cardiac conduction system can maintain a cardiac cycle, just as we just described, the nerve innervation to the heart can modulate that cardiac cycle. So, for instance, if we want the SA node to depolarize faster than it normally would, we said normally it would be 65, 70, somewhere in that range. Well, if we need it to be depolarizing at 110 or 120 because we're busy running at the moment, we need to be able to tell it to speed up. So sympathetic nerves will do that. If we want it to slow down, parasympathetic nerves will tell it to do that. Similarly, if we want the AV node to increase or decrease the retardation of the impulse, in other words, to change the PR interval, then sympathetics would tell it to shorten the PR interval, parasympathetics would tell it to lengthen the PR interval. So the nerve supply to the heart modulates the cardiac cycle. It doesn't cause the cardiac cycle.